Sorry.
Good afternoon. My name is Crystal James, and it's my pleasure to welcome you to the first annual William Bill Jenkins Lecture Series. We have an awesome panel for you today to discuss systemic racism in the time of COVID-19. I serve as the head of the Department of Graduate Public Health in the College of Veterinary Medicine here at Tuskegee University, and I will serve as the moderator for this afternoon's panel discussion. Before we get started, I want to share with you the reason this lecture has been added to the Rural Health Lecture Series here at Tuskegee University, and why we're asking you for contributions to endow the Bill Jenkins Lecture as a part of the college going forward. I'm here at Tuskegee University because of the mentorship of Dr. Jenkins. He told me that if I wanted to influence public health policy, I needed to go to law school instead of getting the PhD in environmental policy that I planned to pursue. His words were, "You will be unique among your peers, and you can help me understand the language lawyers speak." After completing my JD and PH, I had the pleasure to serve on the advisory council that developed the concept paper for the only public health program in a veterinary medical college in a historically Black college or university in the United States. I returned here in 2016 to assist the program to achieve accreditation, in which we are on target to achieve early next year. If you could all remain on mute until the panelists have finished their presentations, then we'll respond to your questions from the persons who have their hands raised on Zoom, questions from persons participating in the chat feature. And so with these ground rules stated, I would like to take just a few moments and introduce you to the panelists for the discussion this afternoon. Dr. Diane Rowley is Professor Emeritus at the Department of Maternal and Child Health, Gillings School of Global Public Health at the University of North Carolina at Chapel Hill. She's a medical epidemiologist whose research focused on disparities and inequities in pregnancy and infant health outcomes. She collaborated with others to develop a theoretical approach to research and evaluation of health inequities among African American populations. Dr. Rowley has a broad range of expertise in maternal and child health, publications on pregnancy and infant health, a track record of funded community-based participatory research, and experience in program and evaluation. From 1990 to 1997, she created and directed the Centers for Disease Control and Prevention's research initiative on racial disparities in infant mortality, and was the initial manager of the CDC National Maternal and Child Health Epidemiology Program. Prior to joining the UNC faculty, she was founder and director of a research center on social determinants of health disparities at Morehouse College, Atlanta, Georgia. The center supported undergraduate student faculty research teams to carry out community-based participatory research across the state of Georgia. Dr. Rowley received her medical degree from Meharry Medical College, completed a pediatric residency at Virginia Commonwealth University, completed the CDC Epidemic Intelligence Service Training Program, and a preventive medicine residency at the CDC. She has a Master's of Public Health from the Harvard School of Public Health, and she's a fellow of the American Academy of Pediatrics, a diplomat of the American Board of Preventive Medicine, and is a fellow of the American College of Epidemiology. Dr. Noble Maseru served for more than a decade as health commissioner for the City of Cincinnati Health Department, where he oversaw over 400 employees in 7 districts, 7 preventive and primary care centers, 22 school-based health centers, environmental, surveillance, chronic disease prevention, public health preparedness programs, and creating healthy community initiatives while managing a budget of over $49 million. Maseru devoted his energies to achieving a healthier Cincinnati through establishing strategic partnerships with numerous public, private, and grassroots agencies with the overall goal of elevating the department's health equity impact on Cincinnati, particularly vulnerable and underserved populations. Previously, he served as a director and health officer for the City of Detroit Department of Health and Wellness Promotion, vice president of the Greater Detroit Area Health Council, Southeast Michigan's leading coalition of business, labor, healthcare providers, consumers, and government, a consultant to the USAID African Division and the Congressional Black Caucus Foundation, and as well as the faculty of Clark Atlanta University School of Social Work. His work with the Public Health Sciences Institute at Morehouse College to promote academic and research collaboration between historically Black colleges and universities led to the establishment of the Academy of African American Public Health Programs. Maseru also the founding director of the Morehouse School of Medicine's Master of Public Health Program. His primary research interests are public health policy issues associated with socioeconomic development of municipalities as it relates to social determinants of health, the health in all policies perspective, and the public sector's role in achieving health equity for its citizenry. He holds a Bachelor of Science degree from Wayne State University in Detroit, a master's degree in public health from the Emory University School of Medicine, and a doctorate in health policy from Clark Atlanta University. Last but not least, Dr. Claude V. Hill is Vice President of Scientific Engagement at the Alzheimer's Association. In this role, he oversees strategic efforts to create global awareness of the association's international research program. Prior to joining the association, Dr. Hill served as the Director of the Office of Special Populations at the National Institute on Aging. In his 6 years at the NIA, he led the development of the Health Disparities Research Framework, which stimulates studies focused on health disparities related to aging. Dr. Hill also directed the Butler Williams Scholars Program, which provides yearly training for early career investigators interested in aging research. Dr. Hill earned his PhD from the University of Michigan School of Public Health, where he trained with the Center of Research on Ethnicity, Culture, and Health, and the Program for Research on Black Americans. He is an alumnus of the National Medical Fellowships Incorporated / W.K. Kellogg Foundation Health Policy Fellowship Program. Dr. Hill holds a master's degree in public health from Morehouse School of Medicine, and he received his Distinguished Alumnus Award in 2019. As a member of the Centers for Disease Control and Prevention's Public Health Prevention Service, a training and leadership program, he helped to establish the Center for Bioethics in Research in Healthcare at Tuskegee University. So ladies and gentlemen, without any further ado, I'd like to introduce you and turn the floor over to our first panelist, Dr. Diane Rowley.
Thank you, Crystal. It's a pleasure to be here with you this afternoon and to talk about one of my favorite people and my husband, William C. Jenkins. And since this is the first annual lecture named for him, I wanted to use my time to talk about Bill's background, a little bit about his history and what drove his life. So may I have the next slide? William Carter Jenkins was born on July 26, 1945 in Mount Pleasant, South Carolina. He was delivered by Rosella Wilson, his grandmother and the local midwife. Fondly known as Billy, he grew up with two rich cultural heritages. Next slide, please. In his youth, he resided in the Gullah Geechee community of his maternal family in Mount Pleasant, South Carolina. Next slide. Next. But he also spent time in the rarefied old Charlestonian houses and businesses owned by the Jenkins family. The Jenkins family owned several businesses, including a restaurant and a funeral home and a newspaper. The patriarch of his family, his great uncle, Reverend Daniel Jenkins, founded an orphanage in 1891. And that orphanage continues to serve Charleston today, known as the Jenkins Institute. Next slide. Slide. In the fall of 1963, Bill enrolled as a freshman in Morehouse College in Atlanta, Georgia. He had to take speech every Saturday for 2 years to eliminate his Gullah accent. Early in his stay at Morehouse, Bill was a foot soldier with the Student Nonviolent Coordinating Committee and was jailed with John Lewis for demonstrating against segregation in front of the Pickwick restaurant, which belonged to Georgia Governor Lester Maddox. Eventually, he graduated with a degree in mathematics in 1967. Next slide. He began his career as one of the youngest African Americans to join the U.S. Public Health Service Commissioned Corps in 1967. He was a statistician trainee in the National Center of Health Statistics. During those early years, he was a biostatistician by day, and after hours, he was a radical activist. Next slide. Two experiences early in his career set his trajectory for a lifetime commitment to bioethics and to developing a diverse public health workforce. Those two were his attempt to end the Tuskegee study of syphilis in the Negro male and his realization of the need for public health scientists that represented the people that they served. Next slide. In the early 1970s, at the time that he first learned about the infamous Tuskegee study of the syphilis in the Negro male, there was no informed consent process in the United States, nor was there a bioethical review of research that's traditionally done today. Next slide. The men were not told they had syphilis. Bill was troubled by the ethics of the situation and spoke to his supervisor at that time at the National Center of Health Statistics. "Don't worry about it," his supervisor told him. And later, it was much later, that he learned that his supervisor was among the scientists involved in monitoring the study. His work to try to end the study was not completely successful, and he was deeply disappointed that he could not get anyone to pay attention enough to end the study. Still, his experience with confronting the immorality of the study changed his life and sensitized him to the fact that medical research could be biased against people of color. Next slide. But today's inaugural seminar series is an outgrowth of his second experience, which occurred in 1970 at a meeting of the American Statistical Association in Canada, when he attended a panel on the status of Black Americans. Only one Black American was on the panel, and only 4 African Americans, all young men, were in the audience. Later in his life, he wrote about the anguish they all felt when they realized that there were less than 5 African Americans with PhDs in either epidemiology or biostatistics. That's when Bill made a pact with the men to complete his PhD and to make sure that there would be a workforce of African American public health experts with a cultural perspective on Black health. He considered the development of the workforce to be social justice work. And for him, this workforce development is his most important legacy. Next slide. The programs he created produced over 400 public health professionals. He loved mentoring. He latched on to students, or they latched on to him, and he never let them go. Next slide. 2 of his very best and brightest are represented here today, Crystal James and Carl Hill. He met Crystal when she was an undergraduate and Carl around that same time, and followed their careers throughout his life. A standard question he asked his public health students and he asked just about every young person he met, was how they planned to change the world. With the COVID-19 epidemic, that question is incredibly timely. The past 2 months have seen the world change tremendously. In the US, we experienced the public health response to COVID-19 through the lens of structural racism and immoral neglect of vulnerable populations. The media has finally been sensitized to what some of us in public health have been talking about for close to 3 decades. Health disparities exist because of social forces, particularly racism. Next slide. This is my final slide. Reverend Dr. Barber, co-chair of the Poor People's Campaign, has made it clear that COVID-19 is teaching us that living wages, guaranteed health care for all, unemployment, and labor rights are public health strategies. Today in this seminar, I want the attendees of the seminar to consider a discussion of what we're doing as public health servant leaders to support this work. Thank you so much.
Good afternoon, everyone. It's indeed a privilege to have the opportunity to share the panel with my dear friend and colleague, Diane Rowley, as well as Carl Hill and Crystal James, who are living examples of one dimension of Bill's legacy, his commitment to social justice through workforce development. The second dimension was his commitment to bioethics. And my remarks will focus on workforce development and tangentially address bioethics. I'm not your Negro. Like James Baldwin, Bill was nobody's Negro. And like Fred Hampton, he was a revolutionary. He picked up the baton of advancing social justice and confronting institutional racism. He did this both intellectually and practice-wise. And so, as our first slide depicts, as depicted in our first slide, equity in the opportunity to seek solutions to COVID-19. In Langston Hughes' poem, "What happens to a dream deferred? Does it fester or explode?" I'm going to more or less enter the thought of does it implode, and hopefully as we have our discussion, you'll get the sense of what I'm meaning here. Next slide, please. So, social justice for social change was Bill's mantra. And like his views, we don't see COVID-19 as an isolated moment. And so like the Sankofa bird that's depicted here, looking backwards and addressing and seeking what took place in our history so that we can move forward and not make the same mistakes that we did in the past, and also looking in the past and figuring out what was successful in the past and utilizing and employing those things that were successful in the past and putting them into practice for our present. So Bill's eyes were always on the people and our Black intellectual history. Institutional development. Bill more or less believed, next slide please, that repairing the deep historical and enduring harm that we as African Americans experience through chattel enslavement required a strategic and systemic response, that we are not disposable and are commodities, as Diane alluded to, that there is resilience, and that through the development of our institutions, we can bring back change. So Bill's focus was for African Americans for improvement for the collective was in the survival and progress through our institutions, meaning the minds, intellect, and commitment to social justice of what those institutions produce. Next slide, please. So Bill was also sensitive to the intersection of the history of public health and social medicine and the Black freedom struggle. It's not the man, it's the plan that we'll achieve and be able to achieve in spite of racial oppression, that we will be able to advance through the development of institutions. Next slide, please. Sisi kwa sisi, Kiswahili, us for us. So in view of the repeated setbacks in civil rights and human rights as depicted here on our screen, Bill's lesson for us was to continue creating opportunities. And we create these opportunities by challenging the structures of racial exclusion, by developing public health scientists and practitioners that will advance social justice and health equity. And in that quest, Bill also had a spiritual consciousness around morality, that spiritual consciousness. Next slide, please. So today, across the nation, many cities have identified and advanced a resolution through their respective city councils that racism is a public health crisis. And that additionally, they have called for a call to action that also merits the development or the establishment of a COVID-19 equity task force. And this is primarily to address the humanitarian crisis that exists in our cities. So there's an old adage that when white America catches a cold, Black America catches what? It used to be pneumonia, now it's COVID-19. So there's an all hands on deck, call. But the question that asked are African American minds who bring an equity lens on deck. And let me repeat that. Are all African American minds who bring an equity lens on deck? As it's been told that all of our skin folk aren't our kin folk. So we're talking about equity in testing and equity in treatment. Next slide, please. So in Pittsburgh, we did an analysis in terms of the distribution of life expectancy. And just as what we've discovered in terms of life expectancy, the range here in Pittsburgh is essentially 22 years differential, from as low as 62 years of age in a neighborhood called Larimer to 84 years of age in a neighborhood called Highland Park. A 22-year differential. And what we're seeing is that just as that distribution, a differential exists in premature death and life expectancy, we're seeing a similar kind of vulnerability that's being expressed in terms of the disproportionate of African Americans who are dying and are being subjected in terms of morbidity with COVID-19. Now what's instructive here is that we know that in 1900, life expectancy in the United States was 47 years of age. And at the turn of the century to the year 2000, it was 77. Of the 30-year improvement, 25 of those 30 years was attributed to improvements around the social determinants of health. The other 5 was attributed to the medical, the healthcare industry. So we also know that today there's $3.2 trillion in terms of the healthcare industry, $3.2 trillion. So that's $11,000 per capita compared to $13 per capita that's spent on prevention and public health. So the key here in terms of when we look at this slide, and next slide, please. That's also reflected in what took place when we were in Cincinnati, a similar distribution. So what we know is that premature death is primarily attributed to pre-existing social conditions. Many of us talk about the comorbidities, but we're talking about what are the drivers that give rise to those comorbidities. And that's when we're talking about the pre-existing social conditions. Next slide, please. So with premature death, those 25 years was the improvement in life expectancy was addressing and having interventions that dealt with these areas around racism, housing, food insecurity, living wage. For example, we know that a high school diploma, if one gets a high school diploma, that adds 10 years to one's life expectancy. So the pre-existing social conditions are what we're talking about. Next slide, please. So those are the factors, these factors that we're seeing, this is what's exacerbating COVID-19 in terms of the impact on the African-American community. And so what Bill was talking about is that addressing these issues, the social determinants of health, and that decision makers, what are the decision makers' determinants of health? And so his ideas that he's brought about in terms of institutional development and establishing minds, M-I-N-D-S, and intellectual acumen to address these obstacles from a social justice lens are key. Next slide, please. So the decision makers as determinants of health. Many of us have seen or it's talked about in terms of the biases, if you will, unconscious and implicit bias. It's more. So what Bill is also saying, talking to us about is that let's not just mark time. Let's not make excuses. Let's address these issues that's responsible for the premature death. Next slide, please. And so what we're looking at is that let's not be excluded from the conversation, which is what historically has been the case, and actually today has been the case. Ergo, the request and the call and the mantra for the establishment of a rapid response team for COVID-19 that's equity driven, equity oriented. So generally we're not invited to the conversation. So what Bill is doing, and we'll learn more about that in terms of the establishment and development of institutions. But historically we know that the National Medical Association, why was it founded in 1895? Was because the American Medical Association, which was founded in 1847, did not welcome persons of color. Conversely, NMA did welcome persons of white Americans to the National Medical Association. Additionally, we know that historically the American Medical Association was not in favor of the advancement of a public health model. And as late as 1967, 68, the American Medical Association did not wish to support Medicare. So at this point, I'd like to pause for a minute and mention Bill's contribution to institution building and advancing social justice and inclusion around bioethics. As Diane mentioned, more than 400 students have gone through these institutions that Bill has initiated and had his ideas come into fruition. We're talking about graduate degrees, baccalaureate degrees, PhDs, postdocs, etc. So in June 1992, Morehouse School of Medicine, in conjunction with other Atlanta University Center institutions, deliberated about the feasibility of developing a Master of Public Health program. And Bill, along with the 3 or 4 other folks, prepared this document, which became in 1993, Bill leads a cadre through the formulation of the Master of Public Health Program Advisory Committee, which more or less morphed into what is now the Morehouse School of Medicine's Master of Public Health Program, which was founded or established in 1994 with the inaugural class in September 1995, of which Dr. Patricia Rodney, under her leadership, it became the first African-American public health program to be accredited at an HBCU school. The Public Health Sciences Institute was established in 1988, which also houses the Project Imhotep. The Black Leadership Lecture Series and Practice in Public Health Practice was established in 1991. In 1992, the Society for the Analysis of African American Public Health Issues, SAFI if you will, was established in the Tuskegee Bioethics Center, where Crystal is at, and Reuben Warren is the director, was established in 1999. And then the Consortium of African American Public Health Programs was established in 2004. And scores of other community-oriented contributions are programs that establish that has Bill's mind print on them. Next slide, please. So there are 5 areas in terms of the principles of health equity, and I'll just more or less focus on 2, which Bill, whenever I was at a meeting or attended a presentation that he was a principal of, he always stated that we must confront institutional racism. And additionally, he always stated that government plays a key role in achieving racial and health equity. Next slide, please. So our continuing fight against institutional racism and other forms of chauvinism must proceed. Next slide, please. And so we must keep our focus on equity. That's our primary goal. And so we should always, since when we're talking about advancing populations or the health of the population, that we definitely have to include equity around the living wage, birth equity, education equity. Again, 10 years added life expectancy just with a high school diploma. So just like voter suppression, as Diane mentioned, Reverend Barber, we have to fight against, not against voter suppression, we also must fight against equity suppression. Next slide, please. So in closing, in closing, Bill emphasized making the connection, always making the connection of inequities with systemic racism. So many of us are familiar with the I Have a Dream speech, and there's one quote in there where Dr. King talks about judge not by the color of their skin, but by the content of their character. So we'd like to extend that to saying not just by the content of their character, but the content of their commitment, the content of one's commitment. So among the several lessons, next slide, please. Among the several lessons that Bill has for us, is that we, African-American people, that we have the power to change our lives. He saw that being answered through the strength of our African-American institutions, building public health intellect, scientists and practitioners, and continuing and expanding that social justice consciousness wherever we are, like Carl Hill at the National Institutes of Health, like Crystal James at Tuskegee, like Laura Elam at CDC. And also let me pause here. We mentioned the 400 folks that Bill has had an impact on. These 400 folks, as I just mentioned, with Carl Hill and Laura Elam, there are others that are in what is called the white historical institutions who are providing mentorship to those other persons of color in those schools, as well as abolitionists who are not white, who are not Black, who are also latching on to the cause of social justice. So like Crystal, James, and others, and you, the viewing and listening audience, wherever you are. And as Ruby Sale says, move into the largeness of who we are. Thank you.
All right, well, hello everyone, and thanks first, Dr. Rowley, for the invitation to be a part of this panel, and certainly to Crystal James for putting this together, and certainly Dr. Maseru for those very insightful comments. I'm just really excited to be here and share a few words on behalf of the many mentees that Dr. Jenkins had over the years, and he was just a magnificent mentor. I especially represent the first class of the Masters in Public Health program at Morehouse School of Medicine, who received direct mentorship. And I had a chance to look at the list of names, and I saw Dr. Kevin B. Williams and Dr. Corey Lumpkin. We were all in the first class together. We all went on to do graduate degrees, doctoral degrees in public health, and much of that I think was inspired by our time with Dr. Jenkins, our time with Dr. Rowley, Dr. Maseru. They all were on the faculty. So this was a family affair back in 1995. Very small program, and to be here today representing the mentees with the faculty. Dr. Maseru was the director, and honoring a legend, I think a mentor magnificent. Dr. Jenkins is certainly an honor. And he would teach us in terms of not only the foundations and principles of epidemiology, but he taught us through these parables and these stories, which when you look back on it, he was preparing us for life, and he was inspiring us to I think to do two things that I remember specifically, and that's to always consider our role in social justice, right? So whatever job you took, whether you were with a pharmaceutical company or a nonprofit organization, how could you really contribute to equity? And once you found out how to do it, it was his phrase that I always remember. It stays with me to this day, and is you have to do the work. You have to do the work, and sometimes that's not easy. It's difficult. It's confrontational. It's telling the truth in places where it's going to be hard. But he was always about doing the work and addressing social justice. So next slide, please. So in this time of COVID-19, I think doing the work is taking a step back and thinking about the justice aspect here, and how certain groups that we know suffer from disparities and are disproportionately affected are overrepresented here in this pandemic. So keeping certain groups or populations in vulnerable social positions demands what Dr. Jenkins really mandated, and that's an attention, a call to action for social justice, and taking a look at the data here that comes from the Centers for Disease Control and Prevention, a place where Dr. Jenkins spent a large part of his career. We see that the underlying conditions are very important: hypertension, obesity, lung disease, diabetes, cardiovascular issues. These are very important for why African Americans are disproportionately affected by COVID-19. And when I mention keeping these populations in these vulnerable positions, I think the term keeping is loaded, right? And it magnifies a connection of lifestyle or health behaviors. So one could look at one level and say, hey, are certain populations overrepresented in smoking behavior, or lack of physical activity, or unhealthy diets? But there's a context, right? It's the connection between health behaviors and context here that I think is so important for the COVID-19 pandemic. And the context links to historical factors. Dr. Maseru mentioned the journey, the chattel slavery, and how that has located people or patterned populations socially in this country. And it leads to what I think are environmental factors that are at place today, determinants that play out today, that have a huge impact on why African Americans, Latinos, and Native Americans are disproportionately affected and are vulnerable to something like COVID-19. So it's hard to talk about American history, as Noble mentioned, without noting the powerful influence of race in the United States. And this influence occurs across, I think, an interpersonal level, for example, where people are, experience racial discrimination on the workplace, or an institutional level, where you live in a certain community and the hospital up the street doesn't have enough masks for you to use when you need to go around to protect yourself against something like COVID-19. And then at a structural level, and I think that's what we really want to raise the awareness with this webinar today, that people's lives are patterned in this country according to race, and their exposure to stress or the situation of having not having access to important resources is ordered according to a hierarchy. And in this country, we know that race and ethnicity is a huge part in determining this hierarchy. So next slide. So I think it's important to note that in COVID-19, the priority populations that are disproportionately affected are the ones that are disproportionately affected by a number of outcomes. We're focusing on racial and ethnic groups, African Americans, Latinos, Native Americans. Next slide, next, could hit it again for me. And so there are, I think, multiple levels or ways to think about this. There are next environmental factors, where people live, the access to resources in those environments, or socioeconomic status. The sociocultural norms and traditions are so important for how people are able to sustain, or the ways that they view work. I think that many African Americans and Latinos are on the front lines of providing care, and they've been kind of patterned and we've been patterned and located in job sectors that put us at risk, and we've got to think critically about how much to perform in an employment because of socioeconomic status. How all of this comes together to influence behavior is the take home here, the context and how that influences behavior. And then last, Crystal, how all of this gets under the skin, or how it influences important biological and psychosocial, or a phrase that I first heard from Dr. Rowley way back in 1995, biopsychosocial. How does all of this come together to influence risk and disparities for disproportionate populations? So next again. So it's, what are the pathways through these levels of analyses that create risk and vulnerability for populations? And I would contend that there's a historical element here. There's a contextual element here that keeps these populations in vulnerability, no matter what the next acute situation is. And if we don't address the upstream factors, the environmental and sociocultural factors, we'll be in this place again when the next acute event arrives. Next slide. So I think some interesting questions to ponder for researchers that are listening in is, how does the stress of COVID-19 exacerbate weathering? Weathering is accelerated aging. People already live in a context where they're facing unique stressors like structural racism and limited access to resources. How does COVID compound, this accelerated aging and weathering for these populations? What are historical factors that locate, disproportionately affected populations in neighborhoods that expose them to risk, or, people that already have respiratory, risk because of where they live? What are the historical factors that led these groups to live in these communities in the first place, or employment sectors? How do these historical and environmental factors influence norms, beliefs, and traditions about high effort coping? So I think about John Henryism and the idea of work and sustaining employment and being in a job that exposes you to risk, particularly during this time, is critical. How does that play out for caregiving? I'm with the Alzheimer's Association, and we know that African Americans are disproportionately affected by Alzheimer's and other dementia. We know that African Americans are more likely to provide caregiving without much help. So how does this play out when African Americans who are caregivers are infected by COVID-19? We're talking about the health of the caregiver and the health of the person that has dementia. So again, a double jeopardy. And then this, I think is interesting, is social distancing might be inconsistent with the stress coping theory, right? So being close, connected to important people in your network is so critical and important. How are our populations who are disproportionately affected coping today, given some of the rules around distancing and COVID-19? So I'll end with, in this time of COVID-19, it shows us that, again, that when we're faced with an acute situation or an acute threat, it is America's most vulnerable populations, African Americans, Latinos, Native Americans, rural populations, those that endure poverty. I would say the already weathered folk who, yet again, feel the brunt and prepare to take on another challenge. to their life over their life course. And what should we be doing? I think there's some discussion that should be had around, given what we're seeing today, prioritizing health disparities research. That means providing resources to researchers who are working in this area, providing resources for training so that we can get the best and brightest minds to become interested in health disparities research in the ways that Dr. Jenkins' legacy continues. And then advocacy, right? Advocacy. Dr. Jenkins was a huge advocate for directing resources to this kind of research. So that's one. Second, I think it's become very clear that, we need a comprehensive public health strategy in the United States that prioritizes providing adequate quality resources, including healthcare, information, all sorts of resources to vulnerable communities. And I think that is an opportunity for us to take off. And then last, I think, once we're able to continue this research and develop this strategy, and we understand, and if we understand that it's the upstream factors, the social, the environmental factors, the political factors that keep these populations in an ongoing vulnerable position, right? We've got to be courageous enough to develop policy change that is a little different from behavioral change, right? Understanding the influence on behavior, we've got to be courageous, as Dr. Jenkins said, in doing the work so that we can make some impact on disparities and protect the health of these vulnerable populations. So I'll kick it back over to Crystal. Thank you.
First of all, I'd like to say thank you to all of our panelists today. I know if we could have a virtual round of applause, that everyone will be clapping at this point for the awesome points that were made, and also the, especially in regards to the memories that were shared about Dr. Jenkins. So as I have displayed for you here, we are seeking to endow this lecture and have it be an annual event so that we can bring people who are moving the needle forward for social justice, and also helping us to ensure that the pipeline of minority health professionals include those that are well-trained in graduate degrees in public health. Come to this space, or whatever space we move to after COVID-19, for meetings to share this type of information with the next generation of public health professionals. Right now, if you would like to contribute to that endowment, if you could send your check in, it is tax deductible to the information that is there on your screen. And so while people are taking advantage of seeing that, I would like to invite anyone who has a comment in particular they would like to share in the space about the honoree Dr. Jenkins in their own experience or with his mentorship. We can take those comments now, as well as we do have a few questions in the chat that I can move to if there are not any people who would like to make live comments at this time. Okay, so.
Hey, how you doing?
Hi.
This is Dr. Kevin Williams. I'm a former student of Dr. Jenkins, and fell in that line as Dr. Carl Vince Hill talked about. I was in the inaugural MPH class, and it's just great to see some of our faculty in here, past director. But just wanted to say real quickly about Dr. Jenkins. The confidence he had in other people. You know, one of the traits of servant leadership is building of other people, and he had that characteristic really good, and he had a different way of doing it, but it was an awesome way in which he addressed it with me. I came to Morehouse School of Medicine, had 3 learning disabilities. One of them was dyscalculus, and I took his biostats. Well, I took biostats at Morehouse School of Medicine and epidemiology. And I remember talking to him about that and how he told me, hey, you can do it. And then, you know, I left the program, was able to do my PhD at UGA, and I had to take, you know, 5 different statistics classes in that program. So he just knew how to build other people. And his commitment, as you've heard, to social justice and building a workforce of those that would be dedicated to social justice is unmatched by many. So I just wanted to make that comment.
Well, thank you so much, Dr. Williams. I see also we have Ms. Sandy Horton, who's the Director of SAFI in our meeting today. Sandy, would you like to say anything to the group before we move forward to questions or comments? I'm sure she's like, thank you, Krista, for putting me on the spot. One of the comments that we have, Sandy, is that you or someone else ready to speak?
I think that was me clearing my throat.
Okay. Well, we did have one comment that should stress be actually listed as one of those comorbidities, if you will, since it is as a contributor to towards the outcome of COVID-19, because patients who don't have those is likely the contributor for those patients who have the underlying conditions that we have that are identified through CDC.
Hey, you know, this is Carl. I'll weigh in on that one. I think, that's a very intriguing research question, and stress, you know, a unique stressor, you know, which is how we think of racial discrimination for, you know, African Americans and Latinos, Native Americans. You know, I think this is something that researchers who have joined us today should be focused in on moving forward, should focus on moving forward. Intriguing research question. I think it's very important. Yep.
And I'd like to add to that, because we are facing this enormous economic stressors due to COVID-19. And I was just looking at some of the information from the several places from the Center for Economic and Policy Research that points out that Black workers are overrepresented in grocery stores, convenience stores, drugstores, transportation, trucking, warehouses, a postal service, and places like Amazon. So particularly in our population, we are facing the stress of having to go to work every day.
That's right.
In an environment where we are told that social distancing is the most important preventive measure we can take. I want to follow that up by saying, in terms of an action step, Carl, that you put into this conversation, we have a responsibility for keeping our community safe and protecting our community. And one way that we need to be on top of that is being very much involved in contact tracing. You know, this is something that here I am living in Georgia with a ridiculous governor who says people can go back to their beauty salons and barbershops on Friday. And those are some of the primary small businesses that Black people own. So he's putting us at risk, supposedly to help our economic stress, but he's just going to be spreading the illness even further in our community. And unless we are on top of contact tracing and protecting people coming to those salons and protecting the business owners, we're going to be in even worse shape.
Yeah.
I just want to throw that out there.
Yeah.
Thanks.
That's a great point, Diane. Here in Pittsburgh, it's almost unimaginable, given the experience in places that you and I and others have been, knowing the importance and value of the community health centers, the federally qualified health centers. So here in Pittsburgh now, we're more or less introducing the the value and importance and the strategic placement and utilization of community health centers in doing just what you just stated. Not only the testing, but also the contact tracing. So that's when we're talking about the determinants of decision makers as being determinants, because they were excluded from the conversation until folks said, no, this is unacceptable. And so we're having a meeting now scheduled for this upcoming Thursday that will involve the health centers, health systems, I should say, the health systems, as well as the local county health department, that we want a co-leadership role with community health centers being in that co-leadership around testing and contact tracing. And testing those individuals strategically that you mentioned, like the grocery store persons and individuals who are home health care folks, because they're being excluded from that strategic conversation in terms of testing.
And I just want to tag onto that. This is Pam Foster in Alabama, where usually we leave that function to the health department. It's not happening here in Alabama. And so thinking a little broadly, I like what you said about federally funded health centers, but maybe even the academic health center should be a part of that as well. I mean, our center, we did some testing out in a rural area, but I didn't even think about the contact tracing part of it. So really kind of thinking a lot more broadly that it is a function for all of us to be thinking about. So I appreciate that comment, Diane.
This is Dr. Williams, Kevin Williams. I wanted to say one thing before I get off for meet with a student. But one of the things, I was on a panel the other day, and one of the things that came up, we had a person on the panel that's doing a lot of the food drives and feeding a lot of, Atlanta public school students. And we were talking about the fact that our community still is iffy on if, are we really being impacted as much as the data is showing? So I think we need a concentrated social marketing campaign that can be led by our academic institutions and in concert with entertainers or whatnot. Because right now you see people making posts saying, hey, don't go outside, but it's not a very concentrated, coordinated effort being led by public health professionals. I think we really need to do that because, some of people in our community are not taking it, as serious. So I think we need to do some type of social marketing concentrated effort, collaboration.
Mr. Nathan Davis has his hand raised. I want to see if he had a question or comment. Nathan Davis.
Well, I can respond to Dr. Williams. I think what's interesting here is, again, this double jeopardy of being in a socioeconomic position where going to work is important. So it's the jeopardy of not participating in your employment and not being paid so that you can have resources to live versus putting yourself at risk, to go out and perform on your job, and I think the fundamental part of this is, being sure that populations have resources so that they can sustain over the life course. We're talking generations of the same populations being vulnerable. So when something like this happens, again, it's the double jeopardy of engaging in employment. And as I mentioned, those sociocultural variables as being so important because high effort coping, John Henryism says that we work beyond all situations, and it could be putting us at extreme risk in this situation.
And just to add a little piece to Dr. Williams' comment about the about utilization of persons in around social marketing and communications, et cetera. I agree, but let's make sure whatever we do, that those individuals have a social equity lens in their work, because right now that's absent. So I certainly agree that to have this marketing and communications, et cetera, but in other words, that philosophy that we're talking about, that Bill instilled upon all of us around having that human dimension and responsibility around transparency and all of that in terms of data, that these decision makers do so through a lens of social justice and health equity and fairness.
I totally agree. That's why it's got to be led by us.
Yeah. Us with that kind of sensitivity and consciousness, because as I said, all of our skin folk ain't our kin folk.
Yeah, you know, I've been in your class enough to know what you mean.
This is Brian Lindsay. I have certainly enjoyed the discussion today, and I believe that Bill would be pleased. I think it's going to be important. You know, one of the things that Bill did really well, so many of them, but one of the things that he really did was he could pick out people and kind of figure out where to put them in places where they could help people and help the causes that he found very dear. Almost like a choir director can determine which voice is going to be best for which song. He could do those kinds of things. And so I think it's important that we remember that, and also that we get in where we can. And it's going to be important for us as a community to get in at every aspect that we can. Right now, there is, we've put a lot of hope and stock in contact tracing. And I do believe that it's one of the mitigating measures that's going to give us some answers to the many questions around COVID-19. The CDC Foundation is right now hiring people nationwide to conduct contact tracing. And so I would encourage all of us to share that information with folks who are coming out of school with bachelor's degrees. The application is a quick one. It only requires that you have a bachelor's degree, and not very much information about the cost of it, but I think we need to flood the application process with people who we believe will help promote the causes that Bill and so many of you promote today.
So,
Yeah,
Brian,
Dr.
do you-
Lindsay, I agree with you about Dr. Jenkins' skill in putting people in positions. You know, Dr. Lindsay and I worked together with Dr. Jenkins in developing the Center for Bioethics and Research in Healthcare in Tuskegee, and you know, he always had a knack for having, you know, maybe a very junior person like myself working with, you know, Dr. Lindsay, who was, you know, coming along more established, but it created this momentum where, you know, Brian and I are in contact, you know, at least weekly about all sorts of things. And that was really the vision, you know, and I think that the you know, the strength, one of the many strengths, as you said, Brian, of Dr. Jenkins, for sure, and his mentoring.
Right. I'm reminded, Carl, that Bill sent you to my office at CDC and you and Zara, another one of his famous
That's right.
mentees,
That's right.
came to my office, and Bill had not called me or said anything, and the only message that he said was, go and introduce Carl to Brian, and there was no more message. It was just like, okay, you know what to do.
That's right. He knew. He already knew. You know. Yep. That's right. That's right.
Brian, I think that is definitely one of the reasons why we wanted to have the lecture here. His focus on the pipeline and the things that he did strategically to ensure that the pipeline would have people of color who have been trained and conscious-minded and focused towards social justice is one of the reasons why I think it's so important for us to have a focused discussion around that topic on an annual basis. So thank you for that.
So Crystal, one of the that I stated that hopefully folks would kind of figure out what I was talking about in terms of imploding. Does anybody have any suggestions on how we can probably strengthen what you just mentioned, Crystal, in terms of our pipeline so that our institutions do not implode and wither away? Or does it need to be strengthened?
That's good. Absolutely. Being in a place right now where we're focused on rural health here at Tuskegee, where there are entire counties that don't have, any space for physical activity, there are many counties in the Black Belt of Alabama that do not have a OBGYN. And so cervical cancer deaths, Alabama is leading in that because of that. And many of these, of course, these Black Belt counties are minority focused, and they have, many of them can get a screening, but don't get follow-up care. So having people in the pipeline that will come to work in these spaces and serve marginalized communities is definitely what we have to do to continue to strengthen the pipeline going forward. Are there any other questions or comments before we close our session?
I think there's a comment in the chat from
Okay. She's suggesting that we work more collaboratively. We aren't in competition. Going in first with PWIs and being leads on funding, not second, so that we can have better control and access over the use of those resources in minority spaces. There's a comment from Dr. Wilson. Anyone else? It suggested that the Black Caucus of Health Workers, the APHA, would be a great place for more of us to collaborate. I agree.
We should also, before we sign off, given what Diane mentioned in terms of Reverend Barber, we should always try to remind folks to get out there and vote and register people to vote.
Absolutely. Any other comments or questions? It's Nia Randall suggests that we could also start in our schools with our youth students, share with their parents what they learn at school, and the students are our future, so starting at the primary level, not just at the bachelor's and master's level. SAFI is also a space that's always open for collaboration. It's one of the institutions that Dr. Jenkins founded, and the current director, Dr. Sandy Hogan, is just reminded me that it's also a great place of collaboration for like-minded people.
So with that idea in terms of the pipeline with elementary school or middle school students, I don't know of any point of shared information. And you know, they have like the Boy Scouts and the Girl Scouts. They have these jamborees where everybody comes together. I'm trying to think of some way that various cities and that are doing things in their respective communities, that some point of being able to have a pipeline for, you know, collaboratively with them in terms of communicating, you know, what everybody's doing at that level. It kind of brings some social cohesiveness around academic progress that's taking place with these elementary and middle school students. I don't know if that exists.
I'm not sure if it currently exists, but that if there's a void, that we can also always look at ways to fill it.
The used to be I'm sure there still exists, the HBCU tours, you know, the school tours that high school students, maybe we could do something similarly for elementary and middle school kids, to not wait for the high school, but just have that done, you know. Anyway, I'm just brainstorming for pipeline.
Well, I definitely know that there is at Tuskegee, we have been working with our undergraduates, because many of them who have traditionally wanted to go into the health professions on the medical side haven't really ever considered public health. And so we work with creating a 3+2 program with a lot of the undergraduate programs that would traditionally feed the health professional programs here and in other places, to help them also leave Tuskegee with a bachelor's as well as the MPH in 5 years as they move forward to pursue their health professions degrees if they continue on the medical school or veterinary school.
Yeah, we're trying to do something similar to that, Crystal. Now, this is out of the elementary, middle school, or the primary school level is here at the School of Public Health at Pitt. What we're trying to do and will do is have a collaboration, again, in the spirit of Bill, is have a faculty and student exchange program with Jackson State University, because Jackson State is the lone School of Public Health at HBCU school. And so in addition to that piece with Marinell and Dr. Payton on the biostat epi thing, is that we also do a human rights pivot around equity with Jackson, the city of Jackson, with Mayor Lumumba, Chokwe Lumumba. So that's something that, you know, again, around what Bill has you know, tossed out, and what we're trying to do here is maintain that kind of institutional strengthening and collaboration. So with the city of Jackson, as well as Jackson State, around human rights and dealing with living wage and things of that nature, and using that expertise that's at historically Black colleges and universities to be exchanged at Pitt at a white serving institution, a white historical institution, and have that exchange collaboration, but also pivoting at the city of Jackson, addressing things around reproductive and you know, birth equity and those kinds of things, economic justice.
Well, wonderful. So are there any other comments that we want to share before we start to wrap up? I do want to again say thank you to everyone who has participated with us today. It has been an awesome kickoff to the Bill Jenkins Lecture. I think he would have approved of not only what was said here, but the spirit and context of everyone who came together in this space to kick off this lecture series. We will endeavor to move this forward. And I know some people need to jump off. It is kind of the middle of the day, so we'll go ahead and wrap up here. But I will say to you that if, as you registered, if you check that you are okay with being contacted, we will send you some follow-up information about how you may contribute to the endowment. And as always, you have the information through the Graduate Public Health website of how to contact us and the other things that we'll have going on for the Rural Health Lecture Series and other opportunities to engage with our public health leaders around the world. So thank you so much all for being here. And I hope we've said something here today, you've heard something here today or saw something in the chat that inspired you to move forward in the legacy and the strategic thinking of Dr. Jenkins to ensure that we have a more informed and better, a more collaborative workforce going forward. So thank you all for your participation, and I'll sign off now. Thank you.
Thank you back.